All right, thank you so much. Welcome, everyone. I'm so glad that you could join us today. My name's Aline Sigler. I'm with Provider Outreach and Education. Also on the line with me today is Ashley Dakota. She's serving as my co-host today. I'm so grateful for my co-workers and colleagues who are so helpful, being my hands and eyes behind the scenes. So thank you so much, Ashley. This session is part of a recurring series where we examine frequent error codes and their resolution for Part A providers who bill Medicare on the UBO4 claim form or utilize the 837I electronic equivalent. There is a similar series for Part B providers, those of you that bill on the CMS 1500. We have a series that analyzes claims from different specialties. You can find those on our YouTube channel if you've missed prior sessions. Today, we're focusing on rural health clinics and federally qualified health centers. As I mentioned, the purpose of this webinar is to review some of the most common reason codes that we see on RHC and FQHC claims. Our goal is to avoid errors. We know they happen, but what can we do about them? If they result in unpaid claims, we want to help you get them processed and processed correctly so that you can receive payment. To accomplish this, first, we're going to start with where I got the information that we're going to discuss. So we're going to look at some data for these provider types, and then we'll look at the top categories of edits, what we're seeing on a recurring basis recently, and then we'll analyze ways to correct and hopefully keep them from happening. You know, even if you haven't seen any of these edits before, this information is going to clue you in and help you if you ever do see some of these types of edits. You might see an edit that is similar, even if the actual reason code itself is different. It's still going to help you in the long run to analyze and process and figure out what you need to do in these situations. Along the way, you're going to notice that I have some resources at the bottom of some of our slides, and that's where you can go to get more information on the topics we cover. It might be a fact sheet. It might be an article on our website. It might be a manual reference where you can see those regulations from CMS outlined. We also have some disclaimers associated with our presentation. Those can now be found at the end of the slide deck, and that's what this little footnote here is letting you know there. Another kind of recent change that I wanted to make sure you were aware of. So let's start with the data. Data plays a really big part in all of our education. And at WPS, we have multiple business units, multiple departments that review claims data on a constant basis. And each department has a different reason for doing so and using that information in a different way based on what their scope of work is and what they're responsible for. So we have a database that we can go into, and it continuously rolls up claim specifics. So I was able to look at and filter that data to find the pool of claim information that we're going to be looking at today. First, we'll start with the time frame. And this was claims that were submitted between March 1st and May 31st of this year. So when I went in to create this presentation, that's the time frame that I had to work with, excuse me. So these were claims submitted between those dates. And I mentioned that because that's not necessarily then corresponding with the dates of service. It may, but it may not. So I just wanted to clarify that. I filtered then for rejected, returned, and denied claims. Because hopefully if we can catch and correct edits before they reject, we're going to save ourselves, and I mean all of us, you, your contractor, all of us, the time and expense of doing adjustments, sending in appeals and waiting for a decision or rebilling. So it's really more efficient for everyone. So then I also filtered that data to just the bill types that you see here, because we're specifically focusing on RHC 71X and FQHC 77X claims. So after I did all of that filtering and sorting, I was given 28,402 claims for that time period that were unpaid. So those results, when looking at the reason behind them being unpaid, showed 12,767 claims that were rejected. So in FIS terms, Fiscal Intermediary Standard System, which is the Part A claims processing system, I don't want to talk down to anybody, but I realize that we might have a wide variety of experience levels on the line. Medicare is full of acronyms, and so we try to define those and step back a little bit and say, okay, if I was brand new, would I really truly understand what the word rejected means? So this means that there was a technical or a billing error. 13,009 errored out and were sent back to the provider's online location for correction. In FIS, in direct data entry, which is what providers use to submit and work claims, return to provider status location is TB9997. Now, claims in this location are not finalized, so they're not approved, they're not denied, but they can't go any farther in their claims processing without some action from the provider. There's something missing or incorrect that only the provider would know or have access to. And so they're sitting there, and they're not doing anybody any good, just sitting there. So what can we do to move them along to hopefully your remittance advice with payment? And then finally, there were 2,626 claims that were denied. Now, the term denied in FIS terms means that there's some question of medical necessity or some coverage criteria that's not met, something more clinical in nature. So rejected and denied, either way, you didn't get money from Medicare, either on the whole claim or a particular service. But the reasons behind it and the actions that you take to get it corrected do vary. And so they do mean two different things. And I myself am guilty for using those terms interchangeably, but there is a difference. And that's why I'm taking the time to explain that to you. So the total dollar amount unpaid for these 28,000 and some claims was $3,121,474. So potentially this is money left on the table that your office or your facility could benefit from. And so that's why we want to take a look at this and see what we. Now this slide is in here just so you can see where you are in your jurisdiction, in your contract. Jurisdiction 5 are providers in Iowa, Kansas, Missouri, and Nebraska, but it could also be some facilities in other states across the country that are part of a healthcare chain or organization. Jurisdiction 8 consists of providers in Indiana and Michigan. So if you weren't sure which contract you fell into, or you didn't realize that we processed claims for more than one, this is just so you can kind of see where you are in the mix. Not to compare the contracts to say one's doing better or worse than the other, because we don't have the same number of providers or the same number of claims coming in. Just so you can kind of see more personally, more specifically, where you are. So when looking at the data, of course, it showed a variety of error codes. in the FIS system, if you're familiar, there are hundreds and hundreds of reason codes. And that's what we call the edits, reason codes. And then the descriptions, what we call the narrative of those reason codes, can sometimes be very similar. So I took the most prevalent ones and I combined them into categories, which we're going to look at in just a minute. Some of them have one reason code associated with them, some have multiple. Then we're going to go into more detail to give you a better idea of what those narratives mean and what we can do about them. So we want to break down these unpaid claims even further than by contract. We're going to look at them by type of bill, and that's what we're going to do next here. For our rural health providers, those RHC claims that were in our data sample, here are the top 5 categories. So as I read down the list, and then we go explore them a little bit more in just a few minutes. We had excluded service billed with covered charges. Medicare is not the primary payer. Not part of a billable visit. Claim is not submitted timely. And value code 44 and obligated to accept as payment in full amounts are not equal. Now that was a mouthful, but again, we're going to explain it in just a few minutes. I'd like to draw your attention to the bottom of the slide here. This is what I meant when I said I had resources for you along the way. You can see this is a link. So if you download a copy of the slide deck, you will have these links. If you're listening to this presentation as an encore, scroll down in the description of the video and you'll see all the links there. So here's your first resource here, and it's a CMS booklet titled Information for Rural Health Clinics. So it's a good resource if you're just learning about Medicare, you're just finding out about what the difference is between these facility types and what we're talking about today. Now on our FQHC claims that were billed on the 77X type of bill, we saw the errors listed here. We also saw claim is not submitted timely, not part of a billable visit, and Medicare is not the primary payer. But we also had some unique ones. Annual wellness visit billed within the first 12 months of Part B coverage, and new patient within 36 months. So those are the ones that rounded out the top 5. Like the previous slide for our RHC folks, we have a CMS booklet down here for our FQHC partners. So now we're getting into the meat of the presentation. We're going to take a look at these error categories. We're going to review the reason code or codes that appeared on the claims data report, give a brief explanation. Some of those reason code narratives can be a little generic. I'd even say maybe a little cryptic at times. So we're going to break that down, what its definition is, and then we'll discuss what we can do to correct and, more importantly, prevent them. First up were rejections related to excluded services billed as covered charges. So the reason code that showed up, if you're not familiar with this and what reason codes are, we have it listed here, 31837. So for this bill type, this is the reason code that showed up on the greatest number of claims within that date span that we talked about earlier, March 1st to May 31st. So the description says that there was a category 2 HCPCS code with a status indicator of M or E1 on at least one line of the claim. The charges were billed as covered, so it appears that the provider was expecting payment. And then I've added the definition as information here so you can see what those mean. M is defined as information used for reporting purposes only. So the system thinks that this HCPCS code informational only. And then the E1 says that it's statutorily excluded. It's not reasonable and necessary. So that's the definition. So when you read the narrative of that reason code, it references those status indicators. So I wanted to define them for you. The resource that I've included at the bottom of the slide here is the CMS webpage for status indicators. What do they mean? What can they tell us? And then what is it telling the system as far as how that claim is going to process? So if we think that the claim has RTP'd or rejected in error, what can we do? First, I recommend that you verify the codes on the claim. Is the code correct? Was it miskeyed when it was billed? If the codes are correct and you believe that they should be paid, put information into remarks to tell the system and the claims examiners why. Give us more information. Because at this point, the system is confused. The status indicator is saying it's not payable, but you have covered charges, so which is it? Chapter 9 of the Medicare Claims Processing Manual, which is 100-04, that chapter is all about billing and payment for RHC and FQHC services. So I've given you that reference here at the bottom of this slide if you want to read the regulations and learn more about it. Next set of reason codes deal with other insurance. And these are historically always in the top 5. We have more beneficiaries working longer and being covered under group health plans than ever before, either them or perhaps a spouse or another family member. So the claims aren't paid because our records show that Medicare is not the primary payer. The reason codes all begin with a 3-4, and then the rest of the digits vary based on the type of insurance that's showing. So rather than list them all out, because there were 7 or 8 of them, if I recall, I just put 34XXX. And then the narrative, of course, will be specific to the different types of insurance. But in a nutshell, it says records indicate the beneficiary has a blank type of insurance primary to Medicare. So that could be working aged, it could be workers' compensation, could be disability, any of those different insurances. So no matter which insurance the patient's record is showing as active and possibly primary to Medicare, the steps that we have to take to verify, investigate, and correct, whether the claim is incorrect or our system is incorrect, are going to be very similar. I also included a link to a Medicare secondary payer booklet. Down here is a CMS Medicare Learning Network product that you can check out. And it's a really good resource for those different types of insurance that beneficiaries may have and what the rules are for each of them to be primary or secondary to Medicare. Now, if you get a rejection concerning other coverage, first thing you want to do is double check the beneficiary's master record. So do an eligibility check. As a Part A provider, you probably know that you're required to check eligibility or ask the patient or the representative questions about other coverage. You may hear this referred to as the MSP questionnaire. That set of questions that you have to ask every time that they come to, every time that they come to your office for a service. You have to do it at every inpatient admission, which I know doesn't apply to this group today, every outpatient encounter, and then every 90 days for recurring services. For recurring services, you do it at the start of care and then every 90 days thereafter. You check eligibility, you touch base with the patient. Has anything changed? Have you changed jobs? Are you at the same job, but they changed insurances at the first of the year? Any of those things to know if the information is still up to date. If the information on the patient's file is incorrect, let's say they retired at the first of the year and their retirement wasn't added to their file. You might have to contact the Benefits Coordination and Recovery Center. They're a specialized contractor that works with CMS, and they're the only ones that can update those files. Way back when I started in Medicare, it was the individual contractors that can open and close those files, and that's no longer the case. If you go to the CMS website, you can put coordination or BCRC in the search field. It'll bring up information for you. You can find the BCRC's phone number, their hours of operation, and all kinds of other information. If you determine that your patient does have another insurance that's responsible for the charges, prepare a bill and send it to them, and then send a secondary claim to Medicare after they've paid or denied it. There's special reporting that has to be put on the claim to, based on the situation and the type of insurance that gives information to Medicare to calculate payment. CMS has some good resources and tools that can help you. I shared one on the prior slide. The resource on this slide is a special edition Medicare Learning Network publication. That's what the SE at the beginning of the number stands for, special edition. And so this one is all about MSP situations. We do also have a Medicare secondary payer playlist on our YouTube channel that you can check out prior webinars that you might have missed. The next reason code is a common working file reason code. It starts with a letter W 7091. And this indicates that a service on the claim is not part of an RHC or FQHC visit. So it means that the code isn't submitted, or the code is submitted, but it's not recognized, or it isn't valid for Medicare. So it's either not on file, or it doesn't exist in Medicare's system, or it isn't billable under certain specific circumstances. It could also mean that the code might be valid for other payers, just not for Medicare. So the first thing that I recommend you doing is check for typos. Look over what was billed. Make sure letters and numbers didn't get transposed. Verify the validity of the code to confirm it's a current, valid HCPCS or CPT code. Next, ensure that the code is billable to Medicare. Some codes, like preventive services, have specific billing rules. Check for codes like pap smears or specimen collection, ensuring they're billed correctly and not bundled with other services unless permitted. Medicare's a tricky program. There's a lot of rules and a lot of exceptions to those rules as well. So there are some gray areas. And so sometimes it just takes practice to learn those rules. This reason code, this W7091, is often seen when trying to bill for services that should be billed on the 1500 claim form to Part B instead of the UBO4 for the RHC's all-inclusive rate. It's often an RTP code, meaning it's returned to the provider. So you could actually go in and correct the claim and resubmit it by storing it or saving it, that F9 code. Again, if you're not familiar with FIS and direct data entry, this sounds kind of foreign to you, but as you learn more, it'll make more sense. The resource that I've listed on this slide is to a different internet-only manual. This time it's publication 100-02, which is the Medicare Benefit Policy Manual. And this link takes you to chapter 13, which relates to RHC and FQHC services. Section 60 specifically is where you can find out about non-RHC FQHC services. Next up is reason code 39011. And this is for claims that were submitted more than 1 year from the date of service or from the through date if the claim spans more than 1 day. Usually not the case for RHC and FQHC, but that's the definition. Some exceptions, again, I told you Medicare does have exceptions. Some of those are identified by CMS. They might be an administrative error, retroactive Medicare entitlement. We see that a lot of times with beneficiaries who are younger than 65 and entitled to Medicare based on disability. Retroactive disenrollment from a Medicare Advantage or a PACE provider organization. PACE is Program of All-Inclusive Care for the Elderly. They are active in some areas of the country. If your claim's been rejected for timely filing, your remittance advice is going to show group code CO, which stands for contractual obligation. So meaning it's provider liable. So you can't bill the beneficiary for these services. They're also not appealable because an initial claim determination based on medical necessity hasn't been made. So what can we do? If you think that you meet the criteria for good cause to waive timely filing, there are certain steps that you have to take to have your request considered. And it starts with an original paper claim form. So you're going to send in a paper or hard copy UBO4. You're going to use the type of bill that ends in a 7. So you're going to be a 717 or a 777. You should also include any documentation that's needed to process your claim. This could look a little different for each person. A letter explaining why the timely filing deadline was missed. Tell us, explain to us what the situation was. And then any documentation that's proving good cause. So depending on what your circumstance is, this could be things such as reports or statements from CMS or even WPS, official letters from the Social Security Administration. This would be especially important with retroactive entitlement. Again, the beneficiary will get an award letter telling them the date that Social Security deems them to be disabled. And then generally, usually Medicare, at least for Part A, will start 24 months after that date. So sometimes Social Security takes years to determine disability. And so that's when we see sometimes those instances of retroactive entitlement. It could be verification of recouped payments from other payers, could be disenrollment notifications when we go back to talking about those Medicare Advantage plans or those PACE programs. I do want to remind everyone that timely filing rejections are not appealable. We work very closely with our claims and appeals departments, and they have told us that they continue to get requests for waiving timely filing on redetermination forms or in a written inquiry to customer service. And that's really just going to delay the handling of your request. It could get lost, it could get denied. But anyway, we want to make sure that we do that correctly. All requests must be sent to the claims manager. You want to make sure you're using the appropriate state-specific address. That can all be found on our website. I've included a link to an article, a resource on our website down here called Timely Filing of Claims. You can read about the exceptions I talked about, and then it outlines the specific steps you need to take in order to have your request submitted and considered. Next, we saw reason code 33981, and its narrative states that the claim was submitted with an incorrect value code 44 amount. The calculated obligated to accept as payment in full course, there is an acronym, OTAF, that amount does not equal the value code 44 amount. The OTAF amount has to equal the charges submitted on the claim minus the total of all contractual obligation group codes. So when you read the narrative itself, either on our website or in the system, it's very wordy. It's got a lot of different, if this or this or this or this. So we're trying to break it down here for you. We don't usually see this reason code in the top 5. So I'm not sure if there was a billing issue or maybe a software issue, like maybe it was applying the value code 44 on all the claims when it wasn't appropriate, or there was some kind of mathematical error within the billing software. It's hard to say for sure. I was kind of surprised to see this one in the top 5 this time, but we're going to look at it, we're going to research it, and then we'll figure out what we need to do to correct and prevent it. So first, let's review when to use the value code 44. Not every claim where Medicare is the secondary payer needs it. Only report value code 44 on claims when there is a contractual agreement with an insurance company. Value code 44 should not be submitted when the provider did not agree to accept a lesser amount than their charges from the primary payer as payment in full. It also should not be submitted when the charges are equal to the amount that the provider agreed to accept, or in instances when payment from the primary insurance is more than the amount that the provider agreed to accept. Value code 44 should be submitted on Medicare secondary payer claims when the amount the provider agreed to accept is less than the charges and higher than the payment received from the primary insurance. To determine the value code 44 amount, subtract any contractual obligations from the primary explanation of benefits from the billed amount. This is what Medicare will use to determine their secondary payment, so it is important that it's accurate. When billing value code 44, you're also going to report the appropriate value code, whether that's a 12, a 13, a 43, whatever, with the amount that's received from the insurance company. Now, those different value codes are based on the types of insurance. If this is new to you, you're not aware of what they are, what they mean, check out some of those earlier resources that I shared on some of the previous slides, and you'll be able to learn more about that. So now that you have that information, you can verify the details of your claim. If it's in return to provider status, you can correct it. If it's rejected, you can do an adjustment to change it. I've also included a link to an article on our website titled Part A Medicare Secondary Payer Billing Procedures. Another good reference for you to learn more about these situations. Now let's take a look at C7301. Again, this is a common working file edit. You know that because it starts with a letter. C stands for crossover. That's just a little trivia tidbit for you there. And the narrative says the claim was rejected because a claim with type of bill 77X, so this appeared on our FQHC list of categories. It was submitted and condition code 65 is not present. The edit specifically flags when a new patient HCPCS code of G0466, which is a new patient medical visit, or a G0469, which is new patient mental health visit. When one of those codes is submitted and the common working file history, so a list of all the prior claims billed for this patient, shows a previous claim for the exact same patient, the exact same provider, and the same HCPCS code within the past 36 months. So the provider is billing a new patient, but we already have a claim with this code for this patient within the last 36 months. So you can see how that would be confusing to the system. So if we need to resolve this reason code for duplicate related edits on new patient visits, we need to identify whether the claim is a duplicate or if the billing data requires correction. So we need to verify if the patient is truly new. By Medicare definition, codes like G0466 and G0469 can only be billed if the beneficiary has not received any professional services from the provider or any of its physical sites within the past 36 months. If the patient has been seen within that 36-month window, you have to adjust the current claim and replace the new patient code with the appropriate established patient code. If the claim's in return to provider status, you can correct it and then store it to move it through the system. So a couple things here. Is it a duplicate? So the same exact claim for the same exact date has already been submitted? Or is it just a mismatch with billing for a new patient when it should actually be an established patient? U5275 also showed up in the top 5 for FQHC claims. And this one, this time the U stands for utilization. It's a common working file edit. So this one states that G0438 or G0439 for the annual wellness visit has been billed within the first 12 months of the beneficiary's Part B coverage. And the system is set to auto reject these claims when this happens. So it's comparing what's on the claim to the patient's master record and common working file, sees that the patient's in the first 12 months of Part B and rejects it. Well, let's step back a second here. When a beneficiary enrolls in Medicare, they're eligible for a different service, an initial preventive physical exam, IPPE, within the first 12 months of their Part B enrollment. A beneficiary is eligible for an annual wellness visit, the AWV, if they haven't received the IPPE or Welcome to Medicare benefit within the last 12 months. If the patient didn't do their Welcome to Medicare visit, they can receive an annual wellness visit after 12 months of Part B enrollment. So we need to make sure that we're checking benefits, we're talking to the beneficiary or their representative, especially for those people that are newly eligible to Medicare. They may not totally understand what coverage they have, what's payable and what's not payable. And so starting to learn about Medicare when you're at the doctor's office is a little tricky. So in some ways, we all have to be advocates for our patients and our beneficiaries to help guide them and educate them about these things. But again, Medicare is not an easy program to try to understand. Make sure you're checking benefits and eligibility before performing and billing for these services. And that's the best way to prevent this error from happening to you. I have included a link to a resource to learn more about the Medicare wellness visits, including the IPPE and the AWV. This Medicare wellness visits down here breaks down and compares actually the different services and what they are and what Medicare will and will not consider. So I hope that looking at those different billing situations and those different reason codes and error categories is giving you some insight and a better understanding into the types of errors that you may experience that we saw in the data and how to deal with them. I know I shared several resources in the corresponding slide footnotes throughout the presentation where you can go to learn more about the different situations. If you downloaded a copy of the slide deck, again, you have those links. If you're listening to the encore presentation, scroll down in the description of the video. That's where you'll find them. Another resource that I wanted to share with you is a tool on our website for looking up specific reason codes, details, and pointers for correcting unpaid claims. Now we've had some changes with our webinar application. I'm going to try to go out to the website. Hopefully it will work for us. Everybody just wants to cross their fingers here. Might take a minute just to make sure that it's safe. Okay, here we are on our website, and the link takes you right to the tool, but I want to show you how to find it without that specific link. So I'm going to go to our homepage. Of course, if you are just going to our website for the first time in a day, you'll have to select your contract and accept a disclaimer that will pop up at you. In this top navigation, under
Elaine?
tools, yes.
I'm so sorry to interrupt. We're not seeing your website.
Oh, I'm sorry. Let me try to go back there. Are you still seeing the PowerPoint?
Yes.
All right. I'm so sorry, everybody. I told you that we had some updates to our webinar application, and so I guess you're not seeing what I can see. So we'll stay on the PowerPoint. Thank you so much, Ashley. Again, I appreciate you being here and letting me know that instead of just talking through and not seeing. So I added this screenshot here, and that's part of the reason why I added this screenshot. So what I did here is I went to tools, there's a drop down, and then I selected all tools. And if you've ever been out there, then there's some tiles or some boxes with a lot of different self-service tools that we have for you. And if you scroll down in the very last row, you'll see this reason/remark code lookup. It'll look exactly like our screenshot is here. And then if you have a reason code that you want to know more about, you can type it here in this box, select the checkbox for reason codes. If you're not sure, you can mark all three of those, the CARC, the RARC, and the reason codes. Claim adjustment reason codes, remittance advice remarks codes. Those are all different ones. And then you hit search and it'll bring up a description, the narrative of that reason code. It'll give you some hints for resolution. And then a lot of times it will link you to other resources that we have on our website that will give you even more information. So when you get a free minute, check that out. And you can even put in any of the reason codes that were in this presentation or slideshow that we looked at today. I have a couple more announcements for you before we get into our questions section here. The first one's on overpayments, and at WPS we receive many overpayment notifications and refund requests from providers. And we know that you want to do the right thing. You want to repay Medicare as quickly as possible, but there can be delays if you use an incorrect or an outdated form. Missing information or sending us checks without explanations as to what they are for are other reasons that can cause a delay. To avoid unnecessary holdups, consider using the Secure Net Access Portal. SNAP is what we call it. It's our provider portal. There are some features called refunds and overpayment claim adjustments that you can use. This is a fast and efficient way to process your overpayments and refunds. There are times when you're not able to use the online portal features, and instead you might have to send a paper request and a paper check. If so, we recommend including the correct form or some other paperwork to tell us what that check is for. We recommend including the correct address also. I'll have Ashley drop a link to an article on our website that'll help you determine which action and form to use. Just wanted to let you know about that. This slide is a provider alert. It's announcing a change to mail delivery for Part A appeals that were submitted in our portal in SNAP. Prior to June 1st, correspondence on appeals submitted via SNAP was sent on paper. Starting June 1st, we've discontinued that. All providers with active SNAP accounts who submit appeal requests through the portal are no longer going to receive those decision letters through the US mail. And if you think about it, it's just easier and more efficient for everyone that way. All appeal letters can be viewed and downloaded directly in SNAP. And what we're going to do now is we're also going to send you an email notification regarding a decision on your appeals, and then you'll have immediate access to that correspondence in the portal. So that was a change in the last few weeks. This next announcement is about the National AV/MAC Ambulance Supplier and Provider Coalition. They have a webinar coming up later this year. It's actually open for registration now. And we've included this slide just kind of as an advertisement of that event. It's going to be held virtually on September 16th from 12 to 2 Central Time, which is 1 to 3 Eastern Time. All the MACs across the country are going to present information on current active medical review, additional documentation requests, and the comprehensive error rate testing or CERT program. So a lot of good information there. If you register, you're going to have the opportunity to submit questions ahead of time, but there is going to be a live Q&A session within that webinar also. If you want to learn more about the coalition, visit our National AV/MAC Ambulance Provider and Supplier Coalition webpage. And realizing that this event may not pertain to some of you on the call, we're just asking for help in sharing this information. This slide is to make you aware of this event. National Provider Compliance Conference is going to bring together MACs and CMS's Center for Program Integrity. Experts there are going to provide compliance professionals with information and tools to effectively and efficiently submit Medicare Part A, Part B, home health, hospice, and durable medical equipment claims. This is a 2-day in-person conference. It has a combination of learning opportunities, including individual presentations, a question and answer session, panel discussions, so lots of good stuff. There's also going to be a dedicated exhibit area to allow for individual engagement between MACs and providers. This is an event for Medicare fee for service only, not Medicare Advantage, so I want to make sure we're clear on that. If you want more information and to register, use the link here, or you can go to our website. We have a big banner. You can't miss it on our homepage where you can go to read the description and then register, because we haven't done face-to-face education in a while, and CMS is getting back to that. So I think this would be a wonderful opportunity. Again, if it's not for you, pass this information on to whomever would be interested. So now it's time for questions. I do need to say any claim-specific questions need to go to our customer service area. Unfortunately, we don't have access to this, so I'm not able to see your claims like they can. I'm going to check in with Ashley now to see what questions you have that have been placed in the chat. If we run out of time, though, don't worry, you will have another opportunity. Ashley?
I am just doing one more double check, Aline, and it does not look like we have any questions in the chat.
Thank you so much. When I'm sharing my presentation, I really rely on Ashley and Mary too. She's joined us today in the background because I can't see what you're putting in the chat. So thankful for that. And like I said, you will have another opportunity to send us questions if you think of them later. So we're just going to move on here. We're asking that you please take a few minutes to complete a survey about this course. Give us information about what you liked, what we could do better. Give us suggestions for topics. You know what you want and need. We can only guess or assume by looking at the data, which we do, but it's your way of letting us know all of those things. Depending on your preference, you have a few options. You can use the link that we're placing in the chat, or when you exit the webinar, you're going to be asked to go to an external site. And that external site is the CMS Qualtrics page for the survey. You're going to get a screen that looks something like this graphic here with the triangle, the exclamation point, and the continue button. It may not seem clear right off the bat what that's for. It is safe. If you click continue, it just wants to take you to that survey. If you're listening to this course as an encore, a box will appear that links you to the survey. And it's going to look like this second screenshot here with the finger and the stars. That'll be your link to the survey. Or you can scroll down to the description of the video and you'll see the link there. If you would recommend our education to others, or tell us how likely you are to attend other events that we host, that feedback will really give us insight into how we're doing and the types of education that you're interested in. In just a few minutes, you're going to receive an email to thank you for attending. I want to personally thank you for attending, but this email contains just some important information that you'll want to be aware of. So don't delete it without reading it. It has your certificate of attendance or your certificate of achievement. It has your name and your contact hours. So if you need to turn that in for credit towards continuing education units, you can use that. If you don't see it, again, it should be coming in the next 5 or 10 minutes. Check your junk or your spam folder and make sure that you have the WebEx email address added to your safe sender list. If you think of a question later, you have 1 week from today to submit those follow-up questions. Send them to our education mailbox, put today's date and something about RHC and FQHC errors in your subject line. That way, those emails will be filtered directly to me. I can prepare a response for you and get back to you. On behalf of myself, Ashley, Mary, everyone else in provider outreach and education, thank you for your participation today. We hope to have you join us for future education, hopefully seeing you join us on some of those other events I mentioned. We look forward to your survey feedback, and you may now disconnect. Have a great rest of your day, everyone.